Thanks, Erin.
The waiting room is almost clear, and I see Beth is logging in now. So we'll give it just a moment longer to get everybody in. I do want to give a friendly reminder to raise your hand. Let's try not to talk over top of each other. The reporter does their best to capture everything. And sometimes when multiple people are speaking, it's hard to capture everything. If you could also identify yourself, especially the first time you speak, so that way the court reporter has everyone's name. And Beth, were you able to get logged in?
Yes.
Okay, I will turn it over to you. Your waiting room is clear.
Thank you. Okay, we'll call the meeting to order. And, is our secretary on?
I thought I saw her log in. I'm scrolling. In the interest of time, I'll just call roll instead of keep scrolling.
Thanks, Erin.
You're very welcome. And I just wrote you guys down as you were coming in. I have Catherine, Hannah. Okay. I have Beth,
Here.
Nina,
Here.
Susan. I believe she said her microphone was not working. Jerry. Heather.
Here.
Garth.
Here.
Steve.
Here.
John. Ishma.
Ashma, yes, I'm
Ashma,
here.
I'm so sorry. I do that every time. My apologies. John. Barry. Kent,
Here.
Mackenzie,
Here.
Mackenzie. Oh,
Yep.
yeah.
Anissa, Sheila,
Here.
Brian, Peggy, Eric.
Here.
Jerry Roberts just came in.
Thank you.
This is Kathy Hannah too. I'm
Oh.
here. I'm having some
Oh.
It's like my internet is something wrong. So I turn my camera off to see if that would help, but if it doesn't, I may have to jump in on my phone, but I'm here.
Okay, thank you.
Okay, do we have a quorum?
You have 11. Yes, ma'am. Sorry, I had to count. I have a hard time calling names and counting at the same time.
Me too, me too. Thank you, Erin. Okay, next up on the agenda is approval of the minutes. Would somebody like to make motion?
I'll move their approval. This is Sheila Schuster.
This is Nina. I'll second that motion.
Any discussion? All in favor, say aye.
Aye.
Okay.
Aye.
Any noes? Okay, the minutes approved. Thank you. Moving into old business, what is the status of Anthem MCO?
Good morning. This is Veronica Judy Cecil with Kentucky Medicaid, and there is no change in the status. Case is
Okay,
still
still-
pending.
Still in the court?
That's correct.
Okay, thank you. Put that on for next meeting. Okay, and then next up is the DMS report on healthcare workforce. And thank you for sending that out to us. It was very interesting, but I think that maybe we have need more explanation and maybe some questions afterwards.
Absolutely. And we have invited Matthew Walton is here from our sister agency, the Office of Data Analytics. And I believe Matthew, I did not check to make sure he was on, but I believe Matthew, there he is going to have a short presentation to kind of go through the high level of the report, and then happy to open it up for any questions.
Thank you.
And Aaron, if you can make sure that Matthew is a co-host so he can share.
I made him a co-host when he logged in. I
Excellent.
tried to grab all of you guys in the beginning.
Yeah, I'm able to share screen, so thank you, Aaron, and thank you, Deputy Commissioner. All right. So let me just thank you for the introduction. My name is Dr. Matthew Walton. I'm the lead researcher with the Office of Data Analytics at the Cabinet. And I have a short presentation for you all to highlight some of the things in the report. I bet I can anticipate some of the questions that you might have. So the point here, excuse me, is to show you all what we did, the challenges that we faced, and then really the biggest takeaway for our team was ways that we can improve the quality of data available to answer questions like this. So really the title here is the question, how many healthcare professionals are practicing in Kentucky? It's a harder question to answer than it may seem. And so this is just a couple slides to do a brief discussion of our 2023 healthcare workforce capacity report. So 3 simple things that this report does. You all are very familiar, I know, with the Deloitte report. It's about 10 years old now. Our charge was to update that report. And in the process, so we read it very carefully. We noticed the things that team from Deloitte was telling us, or telling its readers, what needed to happen to improve the quality of services in Kentucky and to show parts of the state that were lower saturation of healthcare workers compared to others. So we updated that. So we provide a count of credentialed healthcare professionals. What we did, we added 14 more provider types. So we added, for example, in the 2013 report, physical therapists, occupational therapists, speech pathologists, audiologists. There was a long list of professionals that were not covered. In our updated version, we added them. The second is we really grapple. We know that the ultimate interest in this report is to answer questions. Where are we insufficient to meet the demand for the state? That is a very hard question to answer in a kind of empirically rigorous way. I think a lot of people intuitively know when they live in a community that they need another dentist or they need another pediatrician, or where they're deficient at a 30,000 foot level. When you're looking at data, we talk to federal agencies, we talk to medical schools, we talk to several experts, and the best that we were able to offer in terms of a simple and rigorous way to compare Kentucky's ratios was to just compare them to what the nation has. So this is another departure from the Deloitte report. Deloitte constructed measures that said, this is the ratio of people in an area or a county or an administrative or area development district, and this is how many dentists they have, and you should have this many if you want to be sufficient. Their method is sound. I'm not knocking it, but we did not feel on our team that we could support that. We didn't feel like we could defend it because we would prefer to use something like a national association, professional associations ratio that they recommend. And there really aren't things we could find that fit that description. And the third thing I would offer is where we feel the report adds the most value. It's we're proud of the work that we did in terms of counting the professionals. We had to do some data science that we can talk to you all about if you're interested in terms of how to make sure that the data we're using is accurate. But the most important thing is for what we feel like is where we can tell stakeholders to aim in the future, where future authors of a similar report could have better tools to answer these kinds of questions. And so we rely really heavily on the licensure boards. That's the backbone source of data for all of the chapters in this report. And in a supplement that we wrote up, we offer data fields, that if they were to be collected and populated by providers, future authors who are doing the same work that we have just completed will have better tools and be able to answer more interesting and useful questions than we were able to do. This is the last slide. I just chose 3 provider types that I know are represented on this call. And we'll go through just 3 high-level conclusions. And then I think the best use of time would be for me to be available to answer questions that you all may have. So first of all, this is like what I mentioned before. There are some criteria out there in the literature. There's some criteria that some other states use. Our team did not feel like it was our place to tell. I mean, this is stepping into the realm of policy making. What does it mean to have enough dentists in a community? Or what does it mean to have enough physicians? What we felt like we could do really well was give the stakeholder group, here are the ratios. Here's how many we can identify using licensure board data. Here's how many people the census says live in this area. And then here's how that compares to the country. And we use Bureau of Labor Statistics data for for example, how many nurse practitioners there are in the US and how many Americans there are. So where you see green in the report, that means the ratios are at least as good or better than the national ratios. Where you see red, that's where the ratios, and this is a little confusing, that's actually where they are higher. If you think about this like student-teacher ratios, that generally speaking, if your child can be in a lower student-teacher ratio, you prefer that. The same with the way that we're expressing ratios here. This is where in these green area development districts, there are fewer people per dentist, or in Lexington and Louisville area, fewer people per physician. And I think a lot of this won't be very surprising to the people on this call. I've certainly heard this in many meetings around state government spaces, that we know that the area around Northern Kentucky, Louisville, and Lexington is where there's a high concentration of healthcare professionals. And much of the data that we find supports that conclusion, that, you know, if you live in Kentucky your whole life, you tend to think that's how it is. So we would offer that the discussion and the debates about where there need to be more supply of providers are well served by coming to kind of a shared definition of what it means to have enough, or what a certain community needs. What's it mean to be sufficiently supplied? More specifically, these are 30 provider types, so it's hard to say, you know, it's hard to speak very broadly or generally, but a lot of these, Kentucky is broadly in line with the country. Now, the critical challenge to that is if the whole country is undersupplied by, say, nurse practitioners, and we are green on these maps, that is a limitation of this method. And we offer that very freely, that goes back to this first point of, if our only unit of comparison is a whole country that has a shortage of providers, then maybe we will look better than the real on the ground reality is. But I picked 3 points to summarize very simply and shortly. If you look at dentists, you've got 4 area development districts in Eastern Kentucky that look like they could use dentists. If you're looking at mental health clinicians, probably need them most across the whole state, but especially in Western Kentucky. And for those of you on this call that are behavioral health professionals, we try to take a very careful description, because we heard the feedback on the previous report. We do not aggregate professional types and call them mental health counselors. Even this title here is a little bit of a generalization. We know that there's not a licensure type called mental health counselor. This is a compromise we had to make because of the way the Bureau of Labor Statistics collects and data and calls fields. But we have clinical psychologists, licensed clinical social workers, marriage and family therapists. So we have, you know, we know that this is not a singular field, and that it's multiple different disciplines who do slightly different things. I myself am a social worker, so I'm sensitive to that, you know, those distinctions that need to be drawn. And then we probably need physicians everywhere that isn't Lexington or Louisville. I think that was probably didn't need to do a report to know that, but what we can tell you with a little more precision is that Buffalo Trace up in northeastern Kentucky shows up. You can see in these 3, the ratios are worse than the country. So Pennyrile and Buffalo Trace show up in a lot of these maps. So Pennyrile shows up in these 2 as well. When you go through the whole 30 provider types, you see this red show up several other times. And so, you know, to the extent that we can tell you something that maybe wouldn't have already been obvious, those are 2 area development districts that appear to be, if there were to be, you know, an initiative to attract more healthcare workers, we can say that the ratios are the least favorable in those 2, and then a few others that we talk about in the report. And the third thing, which would really be, I know this is also aligned with many sentiments that have been articulated by this group. If we want to do better analyses and have more precise conclusions and answer better questions, we have to ask for better tools. The group of and the analysts on the team that I work on really did a very, very strong effort of doing the very best that we can to say, if Dr. Walton is in Lexington in this data set, and there's another Dr. Walton, but Walton is spelled W-E-L-T-O-N, also in Fayette County, is that the same person? Because what we do is, I didn't talk about this as much, but where those licensure board data have missing fields or potentially incorrect data, we took data from CMS, which is publicly available, and did a linkage strategy to say, let's validate this information. So if it's missing, then we can pull it from this other source. And that dramatically improve the quality of data available to us to write this report. So I'll stop there. And then I don't know if we have much time for questions, but I'm happy that you all were interested in this. We feel like we learned a lot. Hopefully we give something to this group that's useful and meaningful for your efforts.
Okay, thank you for that report. I did have a question, and you kind of answered that, but comparing the numbers in Kentucky to national numbers, to me that didn't seem like it really told us anything, because we know nationally there's a problem. So were you comparing knowing that nationally the numbers were already bad, and so if we were bad in Kentucky, we were even worse than what's we recognize as bad nationally? Is that a fair assessment?
That's not how I would carry. So I would answer your question first with a question. Just forgive me, I'm a former professor, and so I tend to do this. I would ask, how do you know that the quantity nationally is too low? I'm sure we've read a lot of the same articles, but can you give me evidence that what we have nationally is too low?
No, I can't. But that's part of the problem, I guess, in my mind, is that comparing it to national, are we assuming that national is low and then Kentucky is lower, then that shows that there's even a bigger problem? Or are we to assume that nationally it's good, and comparing Kentucky to the national numbers shows that Kentucky is deficit in areas that nationally are good? I couldn't tell the report.
We make no assumption about whether or not the national numbers are good or bad. The reason that they are the anchor is because they're the one thing we can point to and say we can be most certain that this number is true, because we place faith in the Bureau of Labor Statistics and say that's the best source of available information to say this is how many. I should say we trust the Bureau of Labor Statistics and the Census Bureau, because those are the two numbers. Think of it's a division equation, right? The numerator is the number of people in the country, and the denominator is the number of dentists. And those two numbers were the best source of data for us to say, if you're going to compare two things, right, a ratio in Kentucky and a ratio in the nation, the best job you can do is pick numbers you can have faith in. And so this is where our report really is not going to take the whole question all the way to the finish line, because debates about good or bad or enough or not enough rely on work that just hasn't been done yet, in my opinion. We need to do better about making better, rigorous definitions about what it means to have enough.
Okay, so really, it's a number that you can depend on, but we don't know exactly what that number means. Is that what you're saying?
We do know what it means. It's a comparison. You're making some general assumption about the way that people who hire healthcare workers supply their areas. So in that sense, you can say it's at least enough to meet a minimum threshold that the people in the city are comfortable enough with how many doctors they have. The issue is that you just have to take what this report gives you and elevate the discourse to the next step and say, because you have issues about not all communities will need the same number of dentists. You know, if you have a really young population, they're not going to need healthcare the same way that a population where the median age is older. And that gets very challenging. And I think that's why the federal agencies have kind of stopped short and not held out the gold standard that all communities need to hit.
Okay, and then follow up to that question. In the report, we're comparing different types of healthcare providers to the total number in the population. So how do we know, for instance, let me backtrack. We know we have a pretty good idea about what the ratio should be with physicians to population, but we don't know what the ratio should be per population for, say, LPNs, but yet there was a comparison there. So how do I get some meaning out of that with the comparing the number of LPNs to the total number of population, or comparing the number of marriage and family counselors to the population? How do I derive some meaning from that?
Well, so what you would do is you could say it's at least not worse than the nation. And that is, I will grant, it's not the platonic ideal, but you can at least start there. And then what you can do is also derive meaning from saying, how does it compare to the rest of Kentucky? So a lot of how you derive meaning is depending on the question that you need to answer. And that's why we supply you all of the area development districts so you can see how they compare to each other, which may be the most meaningful. I can't say because I'm not the one making the decisions from this report, but you would make meaning you can compare to the country and you can compare to the other area development districts. So you can potentially assume that, let's say that since we can't know for sure if we have enough, and let's assume we have a deficient supply across the whole state, you can at least know where you have the greatest deficiency, and you can target resources there.
Beth, we have several hands raised. I believe it was Dr. Gupta first, then JP Ham, then I believe it was Dr. Schuler, and then Dr. Bobrowski, in
Okay,
that order.
so go ahead with the first person.
Thank you very much.
We're having a
Dr.
hard time hearing you.
Can you hear me better?
Yeah, that's a little bit better.
It's very muffled.
If you can't hear me, just stop and I'll just write it down in the chat. This has been a major topic in our physician technical advisory committee.
I think we should probably move to the next person because we can't hear Dr. Gupta.
If you'd like to drop it in the chat, I can read it off after someone's next question. Thank you.
Okay, next up.
Yeah, this is JP Ham with the Kentucky Hospital Association. Can you all hear me okay?
Yes.
So thank you very much for the presentation. And I do want to applaud you all on asking for better data from all the different licensing boards, because that is vital for our workforce. Where I'm confused is, for example, the KBN, the Board of Nursing, has excellent data, and they do a deeper dive, and your first slide show practicing, and I really focused on that because if you do a deeper dive, and they publish this in their spring newsletter, when you do that deeper dive, you all show the total number of licenses at 70, but the total number of people practicing is more like 48,000. So that's a difference of 20,000 nurses about. And, that difference is people who practice out of state or working for insurance companies or just taking time off. So I'm concerned about the state showing green for nurses when we know that there's a nursing shortage, even if you compare it to Nina's question. And I think it's a little bit misleading. And so I'm trying to figure out, if we want better data, why we didn't take advantage of KBN's better data to show that the number of licenses does not reflect the number of people practicing.
Yeah, thank you for that question. So that was one of the challenges of putting together a report like this, was to try and do justice to the publicly available data that the boards put out. And the Kentucky Board of Nursing poses a unique instance because I agree with what you said. Their data is one of the better, if not the best quality. And they have, because they license so many people, my assumption is they just built up a data infrastructure to handle that much information. Whereas some of the boards, like for example, the board that licenses me is much smaller, and they probably don't have the same budget to manage big data sets. That was a judgment call that we had to make because we didn't want to put data into a public facing report that counteracts. They also have on their web page just the total number of licenses that they have by county. And there's a deeper debate that we could have that we could potentially reflect that in two ways and show, because we did make an effort to do practicing versus not practicing, but not all boards do that. And so it was an effort to try and align all of the provider types with the publicly available information and present it in a way that's consistent. So I thank you for the question.
Dr. Gupta's question, Dr. Walton says, oh, sorry, I got to scroll up. The physician shortage has been a major topic in our physicians' TAC over the past couple of years. How will the data and the recommendations from this report be implemented?
Well, I can minimally respond to that because I'm not a policymaker. So my job is to give the information to policymakers. But what I would really call attention to is there's a little bit of reading between the lines that has to be done. But in the report, we present that medical school graduate degrees conferred in Kentucky's 3 medical schools have been going up over the time period that we cataloged. But then the number of those graduates who go on to get a Kentucky medical licensure is trending down. And I can only imagine if you just think about this like a musical chairs example. We did not look at how many residency spots there are in Kentucky's training institutions for physicians, but I assume that the number of graduates, degrees conferred, is going up faster than the number of residency spots. And we know from some evidence that people will tend to practice in the areas where they train, about half, if you look at the national numbers. And so what I imagine is that while those medical colleges are growing their size of their classes, just by the nature of the way residency training works, they're having to leave the state. And then I would assume many don't come back. So we also replicated analysis that Deloitte did that showed the J1 visa program. It's not, we don't know if a physician has a J1 visa from the data that we had, but we do know if they graduated from an international medical college. So we took what Deloitte did and updated it and found where a lot of the state's underserved areas are being, they're practicing physicians that are graduated from an international medical college. And so that is one lever that can be pulled to recruit physicians to parts of the state that need doctors.
I
Next
believe
question.
Dr. Schuster was next.
Yeah, good morning, Matthew. Sheila Schuster here. Thank you for your presentation. And thank you for supporting something that I've testified on to legislators and did to the MAC, and that is that our licensure boards don't have the data that we need, and KBN comes as close as any. So I'm particularly appreciative of the list of data fields that you all suggest. And I would say to every professional group that's represented on the MAC, we need to find a bill sponsor and require the boards to literally ask those questions. And I always use myself as an example. I've been licensed for 100 years as a psychologist, but haven't practiced literally since 2000, but I've kept my license and done the CEs and so forth, so that when I testify and so forth, I can say I'm a licensed psychologist. But I should not be counted as practicing. And that was an excellent question that Mr. Ham asked. so the county data is helpful, but it doesn't really reflect the practitioners. I want to go back to the mental health groups, and I appreciate you're not having lumped everything together, because that was one of our big complaints about the Deloitte report. And of course, in the mental health groups, you're also not including psychiatrists and psychiatric mental health APRNs, who are a big part of the mental health workforce. They're classified otherwise, so that makes it a little bit different. But I'm concerned about your numbers, and I'll tell you why. You list the licensed psychologist, and my guess is that you looked at just those, I think, 827 who have a doctoral degree. But we have licensed psychological practitioners who are independent practitioners and practice with a master's degree. And there's at least another 800 or 1,000 that weren't counted at all. And that leads me to my next question, which is, you have groups of people listed who require supervision. So you obviously didn't use as your criteria completely independently practicing people. And so if you go back and look at psychology, social work, marriage and family therapy, alcohol and drug counselors, all of them have people that are practicing and that are providing services who are working under supervision. And I guess I'm curious about whether you all thought about including those folks, because otherwise it's very uneven. I mean, LPNs are not independently practicing professionals. They work under supervision and direction of other people. And that's true of a number of other groups that you have in here. So I just wonder if you looked at the supervised people, because they really do provide services, and they certainly are part of the workforce.
Yeah, thank you for the question. So the first point, LPCCs are featured in this report. They are one unfortunate case where what we call LPCCs does not exist in the Bureau of Labor Statistics data.
Right.
They put it together. So in our report, licensed clinical alcohol and drug counselors and LPCCs are put together in a category. And that's a compromise that just had to be made to make the comparison to the national ratio. So they are featured in this report. They're just not we don't call them psychologists.
But you don't include the supervised folks in those fields.
No, we don't. And I'll tell you, I'll respond to that question as well, because we thought hard about that. And really, it's a pragmatic reason, is that we thought we might lose some parts of the audience if we went really in depth about that. We also know that if I'll take myself, I'm a CSW, so I could be under supervision by an LCSW to sit for that. But you end up with the same problem as if I were retired. I don't see patients in my daily work. And so if we were just to see the licensures or the certificates of the CSWs, we don't know which ones are under supervision from our data. And so we could overcount the same way we could undercount. So I think this is one of the best examples of that. We need better tools to be able to answer a question at that level of sophistication, because that's really taking this and pushing it the next level of depth. And we did not feel like what we had was able to do justice to that question.
Well, I would encourage you to go back and add to the psychologists those who are licensed psychological practitioners, because they are independent practitioners. They do not work under supervision. And there's at least another probably 1,000 of them. That's not true of the CSWs, and it's not true of the associates for the licensed professional counselors or the LADCs, but just to put that caveat in there. Thank you.
Beth, and I just had a quick question. I'm sorry, this is Erin. After Dr. Bobrowski's question, in the manner of time for a full agenda, if anyone has any other questions, they can drop them in the chat, and Kelly and I will catch them and send them over to Dr. Walton, if that's okay with him. I know we have a full agenda today.
Yes, that
Right.
would be just fine. We would be happy to answer email questions or however is most appropriate or useful for the group.
Okay, and then when we do that, would you share them with the MAC, Aaron?
Absolutely. Yes, ma'am.
Thank you.
Dr. B, I think was the last person with his hand up. Dr. Bobrowski, I'm sorry.
That's fine. That's all right. I'll try to be real quick. I was hoping that maybe I could give some information on the dentistry part of it, and I'll try to be real brief and hopefully we may answer some of those questions. But I know there was in dentistry, there's provider type 6061 per DMS, and I cannot remember how oral pathologists, which provider type those are listed, but I understand that even they have been are not being paid by DMS. So those are a specialty group of folks that may or may not be included in those numbers. Now, I know a lot of that data. Well, I'll start, Matthew. I want to thank you for your work on that. That's a tough project to get into, but I know some of those reports are based on number of providers per population. Well, the current studies, well, even for the last 40 some years, show that 50% of the population don't even go to the dentist. So sometimes those numbers can be skewed. One of the things we like to look at is the number of paid claims per county or per area. So that kind of gives you a little bit more, I think, knowledge of who's doing the work or where's the work being done. But the licensure boards, I don't believe, I used to be on our dental board, but they typically don't list the provider types. Have to get that information from DMS, but they just keep who's licensed, who's actively licensed to do dentistry. They don't. The problem too is that the MCOs may show a dentist as a Medicaid provider, but they may have quit seeing Medicaid patients 20 years ago. So sometimes those are tough ways to figure out who's doing the work. Sometimes those paid claims, you may have 10 dentists in a county that are listed as Medicaid providers, but only one or two of them actually see the patients. But again, this is stuff that we've all got to continue to work with our legislators and DMS to help on this. But I've got more, but I hope maybe that information might answer some questions. But thank you again, Matthew, for your report.
Yes, thank you, Dr. Bobrowski. You illustrate another thing that we thought very hard about, and if you all, I assume many of you all, the Pareto principle is something I think a lot about when we do this kind of. Some of you all may have heard this, the 80-20 rule. You know, if you look at a church and you ask who are the volunteers in the church and how much, where the tithing and all of that, 20% of the members of the church will do 80% of the volunteer hours. And you see that relationship consistent in all kinds of ways. 20% of a patient panel in an insurance pool will consume 80% of the dollars spent. We've actually seen similar relationships happen because our team does analyses of Medicaid claims as well. So very, very sensitive to the point that you make, Dr. Bobrowski, that we've seen similar things that I can't tell you because I've done an analysis, but if that rule is true and describes the world reasonably well, something like 20% of the dentists will see 80% of the claims or visits for dental patients. And I bet you it's close. It may not be exactly that, but it'll probably be close. And so the remaining 80% of the dentists who don't see very many are there and they're licensed, and it complicates a really thoughtful discussion about, okay, here's our supply. Are we getting what they can do to the people that need it? And that is still a very hard question, and which is why we offer this report with a healthy dose of humility that we don't claim to be able to answer that full platonic question. We rely on all of the partners, and what we can do is give a sort of incremental step in that direction and offer you a roadmap for the kinds of questions to ask or to keep asking to get closer to that sort of platonic ideal. And what kind of tools would you need to get there? And that's really where we think, which is why I want to lean into the fields that the boards can collect would get us closer and closer. Because we ask, how much of your time in a typical week do you spend with patients? Because we know that we have researchers, we have administrators, business leaders, people who are licensed, but do something else with their time versus see patients. And I know that a lot you were kind of putting ideas out there as well as asking questions, Dr. Bobrowski, but is that a suitable response for you?
Yes, thanks a lot. Yes.
Yeah, thank you all. Thank you for your interest in this topic and for the challenging questions. I mean, I appreciate it. We wrestled with all of this stuff as we wrote it. You all have found the parts that we could have probably explained a little better in our narrative. We hope it's useful to you all, and you know, it was a fun challenge to take on and to write, and hopefully it gives you something that you can use.
Thank you, Matthew. We appreciate you reporting to us, and we look forward to hearing answers to more of the questions.
Thank you.
Okay, moving on. Next is update on missed and canceled appointments, and how is reporting going, and is there a common thread as to why patients are not showing up for appointments? And this is the September update, and we have an update every 6 months.
Hi, my name is Justin Derringer. I'm with the Department for Medicaid Services, and have a real brief presentation to show you all. As you all know, we've been working on a no-show or missed appointments dashboard for a while, and we finally got that completed. We'll have a provider letter sent out very soon. And we have been, again, like I said, working on this for quite some time. We initially started out with the attempt of getting well, with the attempt of this being online presentation, and the online version we struggled with because we had some issues with well, various technical issues. So what we done in the meantime is to allow for this no-show dashboard to be available for providers. So this is a provider based only at this time. If you're not an active Kentucky Medicaid provider, you won't have access to this dashboard. But we're gonna do our best to try to, or we continue to work on trying to get this to become a online dashboard for everybody to be able to use and to view. So to start, we will just kind of look at the dashboard's currently available for all providers. It's available in the Kentucky MMIS system, which all Kentucky Medicaid providers have access to. It's under the Kentucky HealthNet part of the Kentucky MMIS system, and it's under DMS reports. There are multiple search parameters in this provider dashboard, and there's a quick chart example. This is all provider types for the calendar year 2023. It allows you to search for all provider types for missed and canceled appointments. It allows you to search for any time parameter that you set. You can search for the week, the month, different years, other different data ranges that can show different missed and canceled appointments. You can break those down as far as provider type. As you can see, these are rural health clinics for the calendar year so far in 2023, and all the missed appointments or canceled appointments for rural health clinics. And then you can break that down even further into reasons. So you can see here, there's the no show, no reason provided was the top reason why appointments were missed or canceled. And you can see the number there. And then if you kind of look back and compare the number of no shows and the number of no reason, that was primarily the only response that we got in this category. So you can see that the biggest gap that we found is no data. So there's no data being entered for a reason. There's just nothing being put there by providers. And so that's probably one of the biggest issues that we found is that there is no data. And then the majority of the data, the majority of the reasons is put in the no reason category. So that's another issue that we found. As you can see, our goal with this no-show dashboard was to create capture accurate no-show data. Of course, we wanted it to be accessible to providers whenever they wanted it, whenever they needed it, and we wanted it to be instantaneous. Prior to that, anytime we ask for reporting, it may take a week or more to get those reports, and then you would only have the specific data you were looking for. This allows providers to be able to look at a variety of different parameters, different time frames, and to be able to have that instantly and to be able to look that up instantly. We see when we look at this data that we need more accurate no-show reasons. That's one of the biggest keys to trying to get this done is to hopefully show providers that we need that information, that we don't have it currently. Again, the biggest number of no-show data responses, there just wasn't a response. There was nothing put in. The no-show was put in there that there was an appointment missed or canceled, but there was no data, no reason given as to why. And then the next biggest reasoning for the no-shows was just the category no reason. So the goal really for us, for the Division of Policy, is to find those areas that are given for reasons for no-show. So when providers have staff reach out to those individuals that have missed or canceled appointments, or when those individuals come in for their next appointment, really trying to get them to describe what those issues were that allowed them to not be at the appointment. And we realized that there will still be a large number of no reason or no data. There'll still be a large number of just simply forgot or couldn't come. But the goal is to get those bottom categories, whether they be childcare, transportation, language barriers, knowledge of appointment times, whatever those things are, that we can figure out exactly what those areas are that are causing the most problems, and then focus on those areas, providing resources there, providing training, providing member outreach, so that we can reduce those missed appointments. So that's all I have. And if anybody has any questions, then I would be willing to take those.
So for the missed appointments, is it just a multiple choice thing where it's usually the staff that's answering these rather than the providers?
Sure. Mm-hmm.
Is it a multiple choice thing where they just choose an answer?
It is. So there's a list of different areas. There are some some miscellaneous ones, but the category that you can put some notes, but there are a list of different choices that you can pick from no reason or no response down to, again, childcare, transportation, communication, language, all kinds of different choices there. And again, like I said, what we found is that majority of the time, none of those are selected.
Okay. Because it just anecdotally from my practice, it seems like the reasons are forgot, the appointment or transportation seems to be the two biggest issues, but that doesn't seem to be indicated by what's being reported. Is that correct?
Partially. So I think the second biggest issue that we found on there is just kind of the I forgot category, which we can start to take. We've already started a work group on possible ways to kind of find some solutions to that. But past that, we don't see that there's a lot of information as far as transportation, any other thing like that that's jumping out. There's just not much data there. So it's either really there's no reason given, or that the reason given is there's no real reason, which is maybe I forgot or just didn't feel like coming or something like that. And we anticipate that they'll maybe be the biggest reason moving forward, of course, but it's those bottom reasons that we're really looking to kind of focus in on to get some proper data on, so that we can attack those as well.
So maybe it's a matter of staff not following up with the patient as to why they didn't come in, and maybe we need to be, as providers, instructing our staff to follow up more closely with the patients to give a better answer. So this can be something.
Yes, ma'am. And that's one of our goals is to hopefully get some better data, so that we can really pinpoint those exact reasons and causes. And that way we can spend some time developing some solutions for those issues.
Okay, thank you. Does anybody have any questions?
This is Angie with Medicaid. I was just going to add to this. It's Angie Parker with Medicaid. I was just going to add to this that this data is shared with the MCO, so they do some reach out to some of the patients if they see
But we maybe need to be even at more of a grassroots level, having providers instruct their staff to contact the patients and ask them specifically why, and then reporting it. And maybe that's not happening.
Beth, this is Sheila Schuster, and I was just going to say, Justin has been so good about reporting for months now at the BH-TAC meetings and working on this. And while I'm disappointed that this can't be public, I do think it's important that it's available to providers. So I think we're back to what you just suggested. Number one, that more providers use the dashboard to report, and number two, that you get your staff to really take that next step and ask the question more specifically about the reason why. We know with the behavioral health members of Medicaid, really important to reach out and figure out why they haven't kept those appointments. And I agree with you that a lot of times it's transportation. Sometimes childcare is the other one that we hear. So this has the potential to, I think, be really helpful to make sure that we're addressing those social determinants of health. Right. Thank you, Justin.
Yes, thank you. Anybody else? Okay, thank you. Then we'll go ahead and move on. The next item is just a reminder that in January we'll have a report on the community health workers and what they're paid, and how they're being used in practices. And again, next up, number E on the agenda is just a reminder that we will have another maternal child update in January 2024. Next on the agenda under old business is PDS rate increases. Remains an item we should get updates on as the process unfolds to case managers, support brokers, and PDS agencies. And this was something that Eric asked us to continue to have on the agenda. And Eric, do you have anything specific that you would like to ask in this regard?
Well, there's been a much discussion amongst social media about the rate increases and continued confusion a little bit amongst parents, representatives in relation to rate increases. And PDS stands for Person Directed Services, which is offered through the waiver programs, most 1915C waivers. Additionally, what we're seeing now is that there's a letter that is going out and some information related to the Appendix K policies that were in place now, but it appears, correct me if I'm wrong, if I state any of this wrong, that they're just going to have a continuation of those current policies until there is an update from well, actually, I guess it's CMS and DMS working related to rate increases, which were enacted in 2022 based upon the ARPA funds. And I know that the Kentucky legislature is going to take this up and continue to review these. But in the interim, though, I think there's still some questions. I have a couple that I'd like to just put out today. In a notice, it says that all policies that are currently approved and in place will continue past November 11th, 2023 until the effective date of the proposed waiver amendment. And so upon CMS approval and implementation of the revised waiver, only Appendix K policies defined in the Michelle P. waiver or other waivers amendment will be continued. I have questions related to that because there seems to be information related to how many hours a provider can be offered at this time. Particularly through agencies like Dial that, they're suggesting now that things in October 1st need to be dialed back down to 40 hours if a parent maybe been providing 60 hours during this ARPA funds period. There seems to be some confusion whether that's going to continue even until November 11th or past that now. So if there could be clarification to that today, that would be great, which could be reflected in the minutes. I think that would be very helpful.
So this is Pam with Department for Medicaid Services. So that was, and I just found out that last night the recording from the webinar that was held on Monday and the slide deck has been posted that goes through the updates for Appendix K and what will be retained going forward versus what will sunset once CMS has approved the waivers. That is on the website. We also are sending out, we're working on right now a participant version of the information that has been shared. But one of the things that is changing or that will be going away is the overtime in PDS and in the traditional services. So, but as of right now, as you mentioned, Dr. Wright, it does continue, will continue until CMS approves the waivers. The waivers are additionally out for public comment as of last night. So we're encouraging everyone to go and review those waivers, but the ability for the overtime, that will be one of the changes that is not continued, and we will be returning back to the traditional limits, which for individuals in Michelle P is 40 hours a week, and an additional limit on that related to parents in all of the waivers is that just regardless of the number of children that are on the waiver, that a parent cannot provide more than 40 hours a week in total, split amongst the children. The child can still get 40 hours a week, but it can't be a parent in combination that provides more than 40 hours a week. The rates are something, the existing rates that are in place. So there are the three changes, which was the 50% for residential, and then the 20% over fiscal year 23 and 24 that were included as part of the legislative required rate increases that we were directed to use the ARPA funds for. Those will remain in place, as well as the 50% rate increase for providers that send in an attestation that 85% of that rate is passed through to the direct care workers. Those all will remain in place. They are written into the waivers. They will remain in place until the rates based on the outcome of the rate methodology study. Once those are determined, then we will do another amendment to the waivers to update the rates. But until that point in time, they will continue to be in the waivers. We're encouraging anybody that has questions to send them to the Medicaid public comment box, and I can put that email in the chat so that everybody has it. We have found that while a lot of the social media groups are well-intentioned, there are some incorrect information that's being shared. But to clarify on some of the other limits that I think were contributing to questions about increasing rates for PDS employees in particular, we removed the $40,000 and $63,000 cap that was on Michelle P. services, because it was not fair to individuals to have an increased rate that was going to limit the amount of services they could get just because the rates increased. So that limit is no longer in place. The 40 hours a week is still in place. Similarly, in HCB, there was a limit of $200 a day. We also have removed that limit because, again, we've increased the rates. It could result in individuals receiving less services to have that dollar cap, but the 45 hours a week service limit is still in place. And there was clarification that just went out about that. And again, we're working on a letter for directly to the participants to explain that a little bit better. But I do encourage everyone, please go out and look at the waivers for public comment. We're in the process of notifying, making sure that all of the tax and other individuals that requested that we send separate notification when the waivers were posted. Kelly is getting all of those out. We did, again, it was last night. It was, I think, close to 6 o'clock that the waivers did get posted. So we're in the process of getting all the notifications out, but we have already started receiving public comment. I started looking at some of them this morning. I think we've received 10 or 15 comments already between last night and about 9 o'clock this morning. So that is encouraging. We do want to hear from everybody once those changes are reviewed, and encourage anybody that has questions to ask those as well so that we can help navigate. We realize the waivers are not the easiest thing to read. The format that they are in is not very user-friendly, but it is what we are required to use by CMS. That is their format. So,
Pam, can I ask a follow-up question to clarify?
Absolutely.
With rates that are currently enacted, is there a form or a document in a PDF format that you could share that shows what those rates should be at the thresholds?
they actually are posted on the website. So if you go to the fee schedules on Medicaid's website, all the HCB rates are posted, and they actually include what the rate was prior to COVID. So what the rate was as of 2019, the rate changes that were enacted through Appendix K, what the rates were for state fiscal year 23, and what the rates are now as of July 1st of 23, so fiscal year 24.
So if you wouldn't mind, if you could share that link maybe in the chat, that would be a helpful thing for us to be able to take a look at maybe during the meeting.
Yeah, I'll go
That'd be
grab
great.
that.
The next question is,
Yes, ma'am.
I was just going to
sorry.
let you know, I've already dropped that in their follow-up email. You don't need to drop it in the chat.
All right. Thank you very much, Aaron.
perfect. The next question is, you mentioned sunsetting and time frame. I think the confusion is we've had October 1st, November 11th, and until DMS approves. Which one relates to the overtime rule? And if you could help clarify that, that would be great today.
For the overtime rule, it is when CMS approves the waiver. And so that will be, we are still working, it's going to be a prospective date. So it will be a future date. We're working with CMS right now to determine what the best date will be for all of our waivers. Because if you have worked with the waivers at all, you know, so each waiver is on a waiver year, and all of our waiver years were different. So for example, Michelle P just restarted on September 1st. HCB just restarted on August 1st. So we're working with CMS to determine what that best future date will be. Once that is determined, we will begin working with the providers to make sure that there is advance notice. So it's not that everyone's it is decided that, okay, it's changing tomorrow, you need to change tomorrow. We want everyone to have time to work with participants to return back to what those overtime, what those units were, and to have enough time to change those person-centered plans.
Well, I have to reference then, I had someone from Dial yesterday in KIPTA reference that there's something that was stated that it was going to be, I guess, April maybe was included in the conversation, a number of people at DMS that stated it was starting the 1st. And so we were speaking with the support broker just yesterday that in at least with KIPTA, they're suggesting that the dial back starts October 1st, and we were just notified.
We are encouraging individuals to go on and start having those conversations.
But it's not
but it is
mandated.
It is not mandated October 1st. And if you have that in writing, or if you can send that to me, my team has been working with the providers and individuals to address any miscommunications.
Yeah, that was something that was miscommunicated yesterday.
So
So
if you
are
can
you?
send that to me, then I can we can address that. But
Okay.
I will say, we are encouraging them. We have not given dates, and you'll see this or hear this in the recorded webinar. We are encouraging providers to start having those conversations with individuals about things that will be sunsetting once that is over. And there's still, as always, there has to be the rationale behind, those person-centered service plans, and has to be supported by the participants' needs. And that has not changed regardless of what the limits were. So,
But just to clarify, just what I'm hearing today, and just in summary, is that not October 1st, not October or not November 11th. It's only when DMS approves is when that
CMS, not DMS, CMS approves that waiver. And so right now, they are out for public comment until October the 27th, and we will be submitting them to CMS for review on or before November the 11th.
Okay. All right. Thank you very much. You've clarified that. That helps a whole lot.
Okay.
Okay, Eric, you indicated that you wanted this to be on the agenda as an ongoing item. Would putting this on the agenda, say every 6 months, be sufficient, or do you need more often to be addressed?
I think if we put it maybe on a quarterly basis until we get the final, the appendix, once we get the final approval, I think that would help just to kind of keep the rate, this the topic out for discussion. Yeah.
Okay, so that would be January, right?
Yes.
Okay, thank you.
Thank you all.
Okay, next up is updates from Commissioner Lee.
Good morning. I am not Commissioner Lee, but I'm Veronica G. Cecil with Medicaid. Commissioner Lee is attending a provider association meeting this morning and speaking to the group. So you get me. I know one of the things that Commissioner Lee likes to share is our enrollment numbers. So as of this week, and this is only as good as the date that it gets pulled. But we do have, excuse me, 1,626,029 members, unduplicated members enrolled in Medicaid. Of that, 142,930 are fee for service, and the rest, 1,483,099 are managed care. Of that number of all Medicaid members, the expansion population, which is, for those of you who are unsure what that means, they are the ones that are part of the expanded federal poverty level limit of 138%. That is 590,249 are part of our expansion population. I also want to give an update on unwinding, and I'm going to share, in the interest of time, I'm only going to share a couple of slides. We did have our stakeholder meeting last week. It was last Thursday, and that presentation is up on our unwinding website. But just for the folks on today, wanted to provide some information about our current renewals and where things stand, and just chat a little bit about kind of what we're seeing for renewals. There we go. This is looking at enrollment across the unwinding period, and you'll see that we are starting that decline. The first set of renewals that were subject to a potential termination was in May. So we saw that on June 1st, the first initial dip. And then as each month passes by, we see additional folks. We knew there were going to be people who were no longer eligible and were going to drop off. I think what our biggest concern is we're seeing an increased number of procedural terminations. And what that means is that the individual has not responded to a notice. There's something they have to do, some action they have to take to respond to us for us to be able to make that determination. And if they don't do that by their renewal date or by the due date, then they'll get terminated. So that's what we're working on. Just a quick glance at what our July renewal, since we did not present this at the last MAC meeting, but we had 54,975 that were in July renewal. That means their renewal date was July 31st. Of those, 27,044 were approved. This is just the snapshot at the time of the July renewal. This aligns to the CMS monthly report that we post every month. So folks can go out and look at that to see these numbers as well. Of the approvals, we had about 82% that we were able to passively renew. That means they had to take no action whatsoever. We were able to go out and ping all the databases, the trusted sources that we have out on the federal hub and some state data resources, and we can perform that redetermination without them having to take any action. But of the terminations for July renewals, 20,344, there were 65% of those that were those procedural terminations. That does not mean that everybody in that bucket is eligible. We send a notice to someone if we've gone out and tried to verify their information and it looks like they're no longer eligible, we'll send them a notice. So even those individuals that, sorry about that, that are no longer eligible, get put into that bucket of procedural termination. You'll see that we continue to have a pending bucket, and the reason for that is we are extending certain individuals during this unwinding period. For long-term care and 1915C waiver members, we're extending them up to 2 months if they've not submitted a response to a notice. We also now have implemented this month for anyone who hasn't responded to a notice, will extend for 1 month. We get 2 months for the long-term care 1915C waiver members, only 1 month for the rest of the population. So we may see that pending number start to climb a little bit. This is also if somebody has submitted something and the state hasn't taken any action on it, then that will be in pending status. So here are the numbers for August, and we'll send these slides out. But like I said, it is on our unwinding website. Again, the different buckets, just to note, so in August of the approvals, 81% of those were passively renewed. They didn't have to take any action. We were able to just go ahead and update their eligibility for another 12 months. And in the termination bucket is about 65% or those procedural terminations. And then again, the pending. So what a member can do if they're terminated is within a 90-day period after their termination, they can respond to that notice. And if they respond and we're able to determine them eligible, we can reinstate. It's an automatic process that happens. They don't have to ask for reinstatement. So they come in, provide the information, we determine them eligible, they'll automatically get reinstated back to their termination date if it's within that 90-day period. So we're tracking those reinstatements too. So this is those people that for whatever reason did not respond prior to their end date, but have subsequently responded in some way. So you'll see, I'm not going to go through all the numbers, but you can see May renewals, the 90-day period is passed, so we're not going to see necessarily reinstatements for under that unwinding flexibility, but folks should still be able to reapply, and we're working through those. June, July, and August, as you'll see, August being the most recent renewal that we've closed. Those numbers are trickling in, but it's good to see that people are at least possibly getting back in if they've been terminated. A couple of priorities I want to go over just very quickly, and that is we're really encouraging households with children that if they receive a renewal notice to respond, because the child eligibility federal poverty limit is higher than it is for an adult. So the adult might think, oh, we're no longer eligible, but really we want to encourage them definitely to send that in if there's a child in the household. The other is just to send it in anyway. If we could make the determination, perhaps they are eligible, maybe they're eligible in some other way. Without that response, we just can't do that. So we're just encouraging everybody to do that. And then, our outreach is really focused around if you're terminated, do what you need to do in that 90 days so we can get you back in. We released a new flyer on our website and just encourage all of our providers and stakeholders that if you have members, you see members, they come into your offices or you're communicating with them, please pull those down, maybe post them, have them available, hand them out. We really want to continue to keep the word out there about renewals are happening. So certainly encourage you to do that. Also just want to remind folks that if you're no longer eligible for Medicaid, that individual could be eligible for a qualified health plan and premium tax and credits that make that plan either zero or very, very low premium. So just trying to encourage folks that if they've been determined ineligible to take that next step. It is different because they have to choose a plan and they have to pay that premium, very different from Medicaid. So just encouraging folks to do that and remind everyone that, that's the next step for somebody determined ineligible. We're tracking QHP, qualified health plan enrollment, because when we see the graph go down for Medicaid eligibility, we want to see the graph go up for QHP. Keeping people covered is critically important. Just a reminder, our website's out there. Lots of information that we include on a regular basis. Social media, if you're not following us on one of the social media platforms, we ask that you do. You don't have to do all three. We just recently, late yesterday, made aware of a scam. It's kind of being recirculated, and we've been seeing that throughout the unwinding. The current one is a phone call, has an 859 number, and the person is really pushing for personal information, bank information, very aggressive. So we're going to be posting something on our social media today to just to remind folks, if there are lots of scams out there, just try to be vigilant as you do that. And it's really hard. They really do just kind of prey on someone's vulnerability. And for providers, a reminder that you can see the members' redetermination date in Kentucky Health Net. It's in there in red. And we have the Kentucky Level of Care report that our 1915C and long-term care providers can pull reports out of. I think that the only other thing I want to mention is that, we pushed a lot of the cases involving children to later in the unwinding period. And we did that because we were implementing continuous coverage for children. So we really are kind of trying to look at additional flexibilities and strategies that we can put into place to make sure that someone otherwise eligible is not getting terminated, that we're doing whatever we can to make sure that we can perform that redetermination. Just doing our due diligence for that. And we have exercised, CMS has posted June 2023, a list of the state strategies available to states. We've elected 20 of those strategies. 2 of them are not available to us, and we're in conversations about whether or not we elect one of the other ones. So we're really trying to do everything we can and take advantage of the flexibilities and strategies that are out there to get through this unwinding period. And then we fully acknowledge the wait times are just, they're not good on our hotline, on our call center lines. Again, we're trying to bring people on. We're continually discussing what can we do different. We are bringing more and more people on and getting them trained, not just for the call center, but to do eligibility determinations. So we're trying to work on it. I think there's a couple questions.
Yeah, Veronica, I had my hand up, and thank you for your information today. So a concern that I've had posed to me through a couple platforms are individuals who are on waiver services that have a child that's 17, and they are going through the process of guardianship, and they're also going through the process of having to now, even if they were medically deemed necessary, without the financial ability to meet the criteria for Medicaid, for waiver services through the 1915C waivers, they have to reapply for SSI. And in the interim, though, they've been notified that if they don't get the approval, they're going to be terminated from the Medicaid waiver program. Someone who's gone through this myself in the last couple of years with my daughter, that process of SSI approval can take 3 to 4 months. Can you explain to me how you guys are going to address that issue? Because it sounds like that the timing is a little off there. If SSI is not responding within 3 to 4 months, and we're only having, we have to get that SSI approval to meet the criteria at age 18. What's the solution?
It is sure. One thing I would ask is that cases that are complex like that there are different impacts to the member and their eligibility, is for those to be escalated, to be quite honest with you. It's better for us to be able to take a look at them and see what are our options. We have some discretion, but not all discretion. So
the response is that the ombudsman's office is getting very busy with this, and so I don't know if you're all working hand in hand with the ombudsman in the office there, because I mean, I don't foresee that SSI with their same staffing issues are going to see the process being improved any quicker. So I mean, we're still going to see us being 3 to 4 months, and therefore we're not going to be able to see people, because we're seeing, I'm getting a lot of information about that, and all I can do is say call the ombudsman or call Medicaid and
and let us take a look at it, because we, as I mentioned, so we have some flexibilities in being able to extend folks. There are what's called ex parte periods of time where somebody can continue to have that coverage while that process is going. I'm just going to be perfectly candid, though. There are some times we have to follow the rules. And if that rule forces our ability to do something and it comes to a termination, we have to move forward with that action. I think, and I note that, someone posted in the chat that about appealing, and if someone appeals, it does allow them to maintain that coverage as it goes through the appeal process. So that's a a really good note. You know, that's kind of where we are. And we are certainly here to try to help our members navigate this. Again, we don't want to see members, especially our vulnerable population, who have great needs to go without that coverage. So the right course is to try to get that up to us and have us take a look at it to see what our options are.
Veronica,
mentioned ex
I'll
parte.
add that we do not close the waiver slots in these situations. We have a mechanism where we are able to keep them open. So individuals are not losing their waiver slots during that time period where they're doing the SSI, if it's the application or whatever, wherever they are in that process. We do not close. We keep that waiver slot open, and we've worked with several individuals through that process. So
You mentioned ex parte. What is that again?
So that is a period of time where the person is granted eligibility, even though maybe we have something on our, and this is different than the passive renewal, but if we have something, if they're eligible, even though they're being terminated because we're not seeing them, their reason for their eligibility has ended, then we can give them a period of time. It's I think 3 months, 2 to 3 months. They maintain coverage to give them the opportunity to file for example, SSI, or for maybe another Medicaid. They can file a Medicaid application for another coverage. And a lot of times, again, we have to look at the specific case to see, does it fall into something where we can utilize that discretion, or you know, that they're eligible for that extended period of coverage while you know, they try to get eligibility in another category.
Okay, great. Thank you so much. You've answered my question.
Okay, great. I think Dr. Gilbert, you were next.
Yes, it's Kent Gilbert. Thanks, Veronica. Thanks for your help. Listen, I understand that Kentucky's on the list of the 30 states that were required to pause terminations because they've got procedural terminations. So what's the status of that right now? And how does that affect the numbers that you've told us that are you're clearly terminating people for procedural reasons? So what's the mitigation and what's going on?
Sure. So that on August 30th, CMS issued a letter to all the states ensuring that states are processing individuals in a household separately, and at that passive renewal rate. So we go out, we check, we verify income. The income comes back and makes the adult in the household not eligible, but the child is likely still eligible. Several states, Kentucky is not one of them, several states would send the household a notice, and then if that notice wasn't responded to, terminate. In Kentucky, we do separate the eligibility. So if someone is otherwise eligible, we will separate them from that household notice, and they'll continue their eligibility. Kentucky was incorrectly included on that list. We've been in communication with CMS. Of course, with things like this, once it's out there, it's hard to pull it back. So you'll be seeing it get updated. What we've done is, you know, a review of all of our cases. We are going back and just in full disclosure, making sure that nobody was inappropriately. So we're going back, we're looking at households with multiple individuals and making sure that the system did appropriately separate them. But again, we have no evidence that that has happened in Kentucky. So we are not subject to that requirement to pause. And it's not to pause all procedure terminations. It's only the ones associated with that particular issue.
Gotcha. Thank you. And I appreciate that you're taking that kind of care because I think it does make a huge difference. I also was glad to hear about the 90-day, the ability to reapply and get things going. The fee for service folks though, out there, how's that? I mean, that's a mess. What's going on?
Yeah, so we continue to work on it. We're doing the extensions if they haven't responded. I think the other challenge is, these can sometimes be a little complicated because there's a resource or asset test. And we're continuing to educate our eligibility workers to make sure they understand that we have some flexibilities around that. So if something is pending or being denied based on an asset or resource requirement, that we should be moving those on along and not have it hold up for that reason. So we are, I can assure you, just really concerned as well about our long-term care and our 1915C members having to navigate this and make sure that they're not terminated, which if documents are pending, if we've not processed those documents, the member is supposed to continue to be extended until that happens. And we do not retro that termination. It is always going forward. But our system isn't perfect. And so we just continue to ask that when our providers are seeing this, to help escalate those cases to us so that we can take a look at it to see what's going on and reinstate if we need to in the interim. We are one of the solutions for this and for some of the other, again, more complex cases is we're trying to bring up staff and we're redirecting staff from other agencies that can kind of help form a team that we can work on these and get them through. I know one of the other issues is multiple requests for information. So somebody submits something and then they get another request and another request. And unfortunately, that is the difficulty of the process because we have to make the determination based on evidence. And I promise you, we get audited on this every year. So we want to make sure that we have the evidence in our system that if we're determining somebody eligible, that we have the document to back that up. So, but we're looking at those cases too. We've gotten a lot of examples of where that's happened, multiple RFIs.
And it's twice the rate. I mean, the fee-for-service folks are losing coverage at twice the rate as everybody else. And so they also require probably more documentation, which makes it complicated on both sides. And just from constituency side points, it's really, escalating a case. I so appreciate what you're saying, but escalating a case from a user standpoint is not very easy. I mean, you call, you wait 4 or 5 hours to get the wrong person who doesn't know what you're talking about on the phone. You finally get a number, you call that number and it's too late, or they can't take your call. I mean, escalating a case isn't a simple matter. So if you have any advice that we can pass back, I would sure appreciate it, because I know both providers and clients who are having trouble with this.
Yeah, we're working on that. We're working on an escalation path outside of our connectors and agents for this particular reason. So we will be sharing that information very soon. We're getting our ducks in a row so that we can be ready for when we launch that. I fully understand. I will say that we have dug into the fee-for-service terminations. So we know who they are, we know what category they're under, we know whether it's been appropriate. We've also, we did front at the beginning of the unwinding through our allocation of the cases across the 12 months. We fronted, there were a lot of fee-for-service members. They were the ones that were eligible for and should be applying for Medicare, or we've gotten notice that they're no longer eligible from our Social Security file. So there were, definitely a larger number at the beginning. You will see that it is completely tailoring off, though. Not to say that there aren't fee-for-service members and long-term care and 1953 members being terminated, but we are tracking that very closely.
I appreciate it. Thank you.
Dr. Schuster.
Yes, thank you. And I'm so glad that Dr. Wright and Reverend Gilbert brought up some issues around the people on the waivers, because we keep hearing this, people on waivers and fee-for-service, Veronica. So we appreciate that you're looking more closely. Also the scam, and I will just say to people, because I brought this to your attention last night, several of our behavioral health members were getting phone calls, very aggressive, very, very aggressive, demanding information, saying if they didn't give it then they would be terminated. And in both these cases, the people were wise enough to know they had already turned in the information. But I worry because we keep asking people to give their information. And I'm concerned that if we're not careful about how we get that out on social media and so forth. But I appreciate that you all are looking at that. I have a question about passive renewals, and I guess, are there passive terminations? Because we're hearing from people that got a notice that they're terminated and they never got a request for information. They never got anything from you to say that they did to submit information.
No, if we've gone out and the trusted data source tells us that their income is no longer eligible for Medicaid, they will receive a notice that is a pre-populated form to give them the opportunity to verify that information prior to, it's not an automatic termination. The only instance and when somebody might receive something different than that is if we go out and ping the trusted source and it tells us their income qualifies for advanced premium tax credit for a qualified health plan. We want them to get kind of moving in that direction. So they'll get a notice that tells them that. It clearly says your income says that you're no longer eligible for Medicaid, but you're eligible for APTC. If that information is incorrect, they should respond, because we say in the notice, if this isn't correct, contact us. So the reason for that is because the trusted data source is telling us, maybe they've even reported it to us that they're no longer eligible. It generates that notice to get them moving to a qualified health plan to get that process started, so there's no gap in coverage. But we're trying to maybe educate more individuals along that line. But otherwise, if the trusted data source tells us they're no longer eligible, they get a renewal notice to go and do that active process before we will terminate them.
Could you share that notice with us or send us a link to that? Because I think there's some confusion, and maybe because they see the first part and they see they're terminated and the request for information is not, or the request to verify that they think they still are Medicaid eligible is not as clear as it might be. Is that possible to share that notice with us?
Absolutely. Yep, happy to do that.
I would appreciate that, because we're hearing that, and we know that people get confused. As you say, there are multiple outreaches and they're hearing it from lots of different people, but we really want to be sure that people who inadvertently got terminated or got a notice that they didn't understand, and I know you're trying to keep those people in the loop, and we particularly want to get them reinstated in that 90-day period. So we're looking at close to 100,000 people in that 90-day period right now.
And I will say that they get outreach too, as if they are going through an active redetermination. So we're calling them, and their managed care organization is calling them to have that conversation. So, looks like your income's no longer eligible. Would you like to sign up with a qualified health plan? So the outreach to them is similar to the outreach we're doing for the rest of the population going through an active renewal. yes, we're happy to share what that notice looks like. And it's the notice that we used prior to the public health emergency. That this is part of normal eligibility and enrollment processing. So that hasn't changed.
Yeah, I guess my only point is, let's make sure that people know that they have an opportunity to give you different data or to give you some reason why they shouldn't be terminated. And if obviously, if they are not eligible, they're not eligible. We're not asking you to make them eligible when they're not, but let's be sure that they understand that they have an opportunity to give you that information. Thank you.
Veronica, there's a question in the chat from Peggy. She says, I'm curious how we're helping folks who don't have access to cell phones or computers, language barriers, or ones who don't understand.
So that's an excellent question. And, one of the challenges that we always face when we're really communicating with our members in any capacity, and that's why we do have multiple modes of communication. So it's the written notice, the phone call or text, or an email. And if we have any of that on file, that is, we ping all three modes of communication. For language, we're continuing to work on that and make sure that members understand what the path is to navigate, how to get help if there's a language barrier. Probably could do better there as well. And we have been working, and unfortunately it just is taking us some time to try to translate the information into multiple languages. We do a good job of doing Spanish, but not so good at doing other languages, and just continue to work on that. So, we heavily rely on our partners in this area, and we're so grateful for our community-based organizations that are out there in the communities that do help individuals that might have a language barrier navigate the process. So I'm hoping that those individuals are getting connected in those communities with those resources. I will always say this: if we can't prevent the termination, it's what we do on day one after to try to get them back in and make sure they understand. And providers are just a great place for that, not to add to the administrative burden there, but if the person comes in and you see they're terminated, there are ways to get them back on. And, that's why we've really been pushing the literature that's on our website directed to providers on what to do if somebody comes in and they're no longer covered. Just trying to continue to work on that.
Okay, anything else? All right, then let's move on to the update on the mobility crisis.
Yeah, and I think we have Leanne.
Yes.
Here we go.
Yes. Hi, good morning. I'm Leanne Fitzpatrick with Department of Behavior. No, I'm not. Department for Medicaid Services. I'm a behavioral health specialist. I apologize. I have just I'll be very quick. For mobile crisis, our mobile crisis implementation. For right now, we have our SPAs that have been approved by CMS. Those include a redefinition of mobile crisis services that goes along with the CMS show letter back in December of 2022. We have created a new service of a 23-hour observation stabilization service that goes along with our residential. So in that case, if someone needs that, they don't need to go somewhere overnight, but need to be somewhere away from a location or just a stable environment. With that, there would be a medical and a behavioral health assessment to see what services that person needs. With our residential crisis, we updated the definition, updated crisis intervention. Those were approved back in July 20 of this year. The last item is our behavioral health crisis transport, which was approved September 11th. It's a new provider type. This will be two separate situations that say if someone has called 988 and they determine that a mobile crisis intervention services needs to be dispatched. The team gets there and works with that person, tries to de-escalate, and they see that person, it can't be done there on scene, that they need to go maybe to 23-hour, and sometimes unfortunately maybe to the hospital or to a most appropriate higher level of care. At that point, a behavioral health crisis transport provider can come and transport that provider. The second situation is, I know that we have this happens at several locations around the state, that someone walks into the ED or is sent to the ED, and they need to go to either inpatient facility because that ED doesn't have, within the hospital system, has that capability to treat them, and they need to go to a higher level of care. And we can't call 911 because that's not an emergency service or an ambulance or an EMS service. So at that point, the ED somewhere within that system can call the behavioral health crisis transport provider and to be able to provide that person to the next level of care. And I will send this to Aaron to send out to everyone as well. With the SPA changes, also we have, as you know, we're seeking an ASO to oversee this model, provider capacity training, and to oversee multiple levels of funds that have been leveraged. We do have our community crisis co-response model, a new notice out for funding opportunity, and I'm going to put that in the chat for you. We put that out originally this summer, and with increased interest and other feedback from persons that are interested in that, we have reissued that NOFO out. Applications are due October 31st. There is a webinar this afternoon to work with folks that want to send an application in or have further questions. The last thing is, along with the behavioral health crisis transportation, we also have put in a SPA to CMS for treat not transport that is still with CMS. And with that, CMS told us that some of Kentucky's regulations are more stringent than the federal ones, particularly on that EMS cannot get reimbursed. Ambulance provider cannot be reimbursed if they go somewhere else besides a hospital. We are changing that regulation to say that an alternative location, taking a hospital and just putting in alternative location. And I know that there are some questions, so I'll be glad to take them. Anyone go first?
Who, me?
Go ahead, yes.
Yeah, okay, thank you. Thanks, Leanne. I'm pleased to hear about the BH crisis transport, but I'm wondering if anybody's gonna actually start doing it. Do you have any ideas, or are there additional providers coming on board? Because there's such a resources.
So it is a new provider type. And we have heard, like you said, positive about it. So let's say that an EMS, they have the ambulance. If they can enroll in that provider type as well, if maybe they have a van or a car or something else. If the NEMT providers, if they can, follow and meet the criteria, they can enroll as that provider type as well. So we're anxious and we're hopeful that we do have several that will be able to enroll in that provider type.
Okay, good. Thank you. I'll remain cautiously optimistic.
Yes, thank you.
I'll echo that cautious optimism as well, but I was just in a meeting yesterday with House leadership, releasing a statement that they want to introduce legislation to have sheriff's offices, police officers, and various others be eligible to. Is this part of your conversation? Have you been in touch with them? We're curious about this legislation that's going to move in the new session, and I'm just not clear at all how this interfaces. If they're going to have something, it ought to dovetail.
I can take that, Leanne.
Okay, thank you so much.
Sure. So we have, based on previous legislation that's come out, that has directed some of the work that underlies this new model. there have been conversations with various legislators. I can't tell you exactly, you know, leadership definitely, but yeah, some conversations, because they are aware of how we're implementing current legislation, and what, you know, the program is going to look like. And we do have, as part of this, a community crisis response separate. It's a component of what we're doing in this model that allows communities to kind of develop and leverage maybe some law enforcement agencies. The critical piece here is that we're not, you know, this is not to arrest more people. It is to try to get the really important behavioral health professionals in the crisis response. And so that could be a sheriff's office that has a team that meets this definition. So we look forward to seeing, you know, we've had to kind of create this just from scratch, based on lessons learned in other states, because states are doing this in some form or fashion, but not like Kentucky. I mean, I think we really have developed a comprehensive approach for the crisis response. So we'll certainly welcome if there is, and all that is having to be on state dollars, by the way. So we can't, that grant program that we're doing, that separate grant program, is separate from what we can do through Medicaid. So we would welcome legislation that especially gives funding, direct funding to a program like that, as long as,
I wouldn't hold your breath.
well, and as long as it, acknowledges and recognizes that there has to be trained behavioral health professionals.
That is my concern.
As part of that team.
Yeah. My concern is that they work very closely with you, because I think there are great opportunities, but there are also great possibilities for either misuse, abuse, or just plain ignorance. Causing greater harm. I think this is the proposal is, we don't have legislative language yet, but it has a number of very concerning provisions, including this medical transportation piece comes under the involuntary incarceration of the mentally ill. That's the title, involuntary incarceration. And I'm not real, I am cautious. I want there to be appropriate transportation, and I want people to be able to get safely to and from the care they need. I am wanting all of us to be vigilant about making sure that it's from trained folks, whether they're a driver or a sheriff or a deputy or a constable or a clergy person. They need to be meeting those standards, and I hope you'll help keep the legislative branch tuned to that.
Thank you for sharing.
I'll also send Aaron to send out our behavioral health crisis transport policy, because in that there's specific training that's involved, there's specific vehicle recommendations, requirements that are involved. It's required to have a driver and another staff person, so the driver can focus on driving in those situations. So I think the policy does outline some things.
That's great. Thank you.
You're welcome.
Dr. Schuster.
Yes, I'm glad that Kent brought up this proposal from House Republicans. And they use the term confinement, involuntary confinement of the mentally ill, which is never what it's been. KRS 202A is involuntary hospitalization. We're talking about treatment here, folks. This is going the opposite direction from treatment. It's going into criminalizing mental illness. And I am really, really concerned about it. And I hope it doesn't get all caught up in what you all are trying to do, Veronica and Leanne, over at Medicaid, in terms of getting these crisis teams and getting mobile crisis and so forth. I know that law enforcement has been unhappy for a number of years about transporting people after they've had a mental inquest warrant sworn by the judge. And we've had numerous pieces of legislation and numerous discussions. And I don't, there's a lot of different issues here that could end up getting together into a mess. So I just think we really need to be on top of this. Thank you.
That's why we thought it was important that we can't just do 988. We need to include 911 too, and make sure that any anyone responding to the crisis, regardless of where it comes from. There's a consistent response that's appropriate for behavioral health, mental health, somebody with a behavioral health or mental health issue. And then transporting them, what I think is really great is the flexibility that's in our program, is to be able to transport the person to an appropriate setting. And so that, in the past, transportation covered by Medicaid was to the ER, and we're doing away with that. So, we'll be able to assess and get individuals to, a behavioral health treatment provider that we never have been able to do before. So, so we're really looking forward to the impact. It is, we're rolling it out. It's still very much in its infancy. It's not even really been born yet. So, we're looking forward to the implementation and working closely with providers on, making this successful.
Thank you.
Thank you, everybody. I just want to note that we have about 30 more minutes to the meeting, and we have a lot more to cover. So this meeting is probably going to run over. So I just want to give everybody a heads up about that. Next up is MCO's report, 98 to 99% adequacy compliance for services. A Kentucky third-party contractor, the IPRO, it's only 30% compliance. There's a concern that compliance does not address actual accessibility services. So we had requested a report to address the discrepancies between the MCO report compliance versus the IPRO report.
Good morning, good afternoon almost. I think we have one more minute. But I am Angie Parker. I'm the Director of Quality and Population Health within Department for Medicaid Services. And I have with me today Chuck Merlino, who is our account manager for our external quality review organization contract known as Island Peer Review, also known as IPRO. And I'm going to go through some of the high level of what network adequacy, access and availability, and what the secret shopper survey process is all about. So first of all, what is the definition of network adequacy? And what we have here is this is CMS definitions, that we must ensure that Medicaid and CHIP managed care plans maintain provider networks that are sufficient to provide timely and accessible care to our beneficiaries across the continuum of services. The access and availability contract requirements are as follows. For urban areas, they have to be within 30 minutes or 30 miles of their place of residence or work to the extent that services are available. In non-urban areas, PCP and hospital services are to be within 30 minutes or 30 miles of their place of residence or work to the extent services are available, and other providers within 50 minutes or 50 miles of their place of residence or work to the extent that they are available. MCOs may request exceptions to network requirements due to challenges meeting the network adequacy, such as workforce shortages, as Dr. Walton went through earlier. I think some of this can align to what he had reported on. And they can also ask to utilize telehealth to meet network adequacy per DMS approval. Appointment wait times per contract and also with providers, MCO's contracts with providers, is you are to be able to see or get in to see a physician within 30 days for routine, for preventive services, or just your yearly checkup. If I were to call today, the expectation would be to be able to get into my doctor within 30 days of that request. For 48 hours, urgent care for 48 hours. And what I mean by urgent care is like sore throat, pneumonia, or a cold. Hopefully people aren't going to see you for a cold, but sometimes they do. And of course, for emergency and behavioral health services, they're to be available 24/7, regardless if they're in the network or not. So what you would ask about is the secret shopper survey. And basically what this is It's a telephone-based survey to evaluate access to and availability of providers participating in the MCO. It assesses the ability to contact providers and make office hour appointments using a secret shopper survey methodology. We change annually. We select different provider types to review each year, and we do a random sample, and iPro does all this, evaluates availability of routine and urgent appointments and after hours access. As I said, it's performed annually by iPro. The methodology, the surveyors are instructed to role play as an MCO Medicaid member seeking care, and there are scripts in which they are to follow that based on routine or urgent type scenarios. And they call providers and attempt to get appointments. They make at least 4 attempts to contact an actual staff person to complete the survey. And subsequent attempts, they call on different days, different times, just to make sure that to try to get in touch with that provider if they haven't been able to do that. In the past 10 years, these are the secret shopper surveys that iPro has done, performed for the Department for Medicaid Services. And the last one was on pediatricians. We've done dentists a couple of times, and actually we're doing them again this coming fall. We're surveying them. So here are the results of the last secret shopper survey. Say that 3 times. With the pediatrician, all MCOs sent information to iPro, and they excluded selected providers based on certain criteria. There were 1,169 providers in the final sample, and they attempted 491 routine calls and 491 urgent calls and 187 after hours calls. The survey was conducted in December 22 and January 23. Your offices may have been contacted. So what were the results? They were able to contact 80% for routine call to get an appointment. And the reasons they were not able to contact the provider was, the number one was that their answering machine or voicemail system. That's what they got. And this was after 4 attempts. And the second would be the telephone message was out of order. Now, if there's any specific questions on what all these means, Chuck can further explain all that. Constant busy signal, wrong telephone number, no answering service, the number of resident or non-doctor business, and put on hold for greater than 10 minutes. That just occurred once. So urgent call contact, they were able to make contact 83% of the time. But again, the reasons they were not able to contact certain providers were basically the same reasons as routine. The appointments made, and this is where the concern comes into play, is only 31.7% was an appointment was made for a routine call. And for urgent calls, only 29.5% when they were able to get through and make an appointment. And the reasons appointments were not made, provider was not on site or no alternative provider available was the main reason. Provider for routine, provider practice restricted to specialty. Those were the top 2. And then they kind of dropped down to provider not accepting new patients, to not a plan participant. Also for non-urgent / urgent calls, main reason was provider practice restricted to specialties. So in this case, for a pediatrician, they may have been a pediatrician that specializes in hematology and something like that.
Yep.
So we do have these reports along with all the quality reports that iPro works on with us and for us on our website. And here is the link. And if you would like to go in and look at the entire report, it is available here. You can do a drop down and pick the year. And I'm not sure, we have a few of the access and availability surveys, but I'm not sure all 11 years are on there. But if there's a particular year or service that you would like to see, we can certainly get that for you. We, like I said, we contract with iPro to do a lot of reports for us and help us with focus studies on different diagnoses and issues with that address our Medicaid population. We also, Medicaid also performs other network adequacy reports that are reviewed internally by Medicaid's expert, I guess you would say. But we have a geo mapping, the MCOs report quarterly, a geo mapping and access report. They are to submit a monthly provider network status report, quarterly a timely access report, and quarterly a provider network adequacy exceptions report. These are all being reviewed by DMS subject matter expert on a monthly or quarterly basis. That was it, very quick. If there's any questions, or if Chuck, if you would like to add anything to this, the information regarding the sacred survey.
Yeah, no, you did a good job explaining the process. The one thing I want to point out is I think that the purpose of this presentation was a discrepancy between what the MCOs are reporting and what iPro's reporting. And I think the big difference is we are truly doing a secret shopper. We're calling on behalf of a Medicaid member trying to get an appointment. And from what I understand, that the MCOs, many of which use SPH Analytics, which is a vendor, and it's not a true secret shopper. They're calling, and their scenario or the script says, I'm calling from so-and-so health plan. And then they ask several questions. So you could get a different response knowing that you're calling from one of the plans versus it's, they think it's a member calling. So I just wanted to add that because I think that was one of the things that you were trying to look at.
Yeah, it's not exactly apples to apples on what the MCOs are doing as far as a secret shopper versus what we're doing, what iPro is doing. Dr. Schuster, you had a question?
Yeah, thank you, Angie and Chuck. It looks like you only do a secret shopper once a year for a designated population of providers.
That is
correct.
That
right?
That is correct.
Okay, because I saw where behavioral health was 2014, so could I hope that it might come back around in 10 years? And how often, because you've got
we'll put
lots
that
of
on the list for next year.
I'll put in a motion that you come back and do behavioral health at some point, but it could take you a long time to get through all of the provider types, I guess is what I'm saying. So
I was thinking we did it in 2021. We did behavioral health providers, alcohol and substance use disorder providers. I was thinking that we had done something like that in the time that I've been with Medicaid.
Yeah.
Well, it says 2018 it just says alcohol and other drug providers. It doesn't
right
say
here. I mean, of 2014, but right here in 2021, we did a few different providers.
Oh, you did a whole bunch of providers.
We did a whole bunch.
All right. Well, let me go and look at 2021 then.
Okay. If it's not, I'll make sure it's not. If it's not on the website, we'll send that to you.
Okay. Thank you. I appreciate it.
Mm-hmm. Does anyone else have any questions? Know if there's anything. Okay. Well,
thank you.
Okay. If anything else comes up, you can reach out to Angie and we'll get you an answer.
Thank you.
Okay.
Okay. We have 20 minutes and we have two things on the agenda where we have to have a quorum and we have some members who have to leave on time. So I guess we need to go through the TAC reports, but we'll have to do this quickly and then we'll have to do the vote for the election. And then following that, we will do the reports from the MCO so that we can have a quorum to vote to approve the recommendations from the tax and to vote for the officers for the MAC. So having said that, and again, I apologize to the tax. We've had a very full agenda this time. But when it comes up for your report, if you would just give your recommendations. And again, I apologize. We'll try to do better next time to allow the tax more opportunity to give information about what's going on with their TAC. So having said that, we'll start with therapy services.
I don't believe anybody's on from therapy, children's TAC, or the hospital TAC.
Okay. So I'll just say it, but then we'll move on. Primary care.
Elizabeth, this is Patrick with the Kentucky Primary Care Association. Is this the correct TAC report?
Yes. Yes.
I apologize.
Just-
Yep. So there are no recommendations at this time.
Okay, thank you. Physician services.
We did not meet.
Thank you. Pharmacy. Persons returning to society from incarceration.
This is Steve Shannon. We met and we have no recommendations. Thank you.
Thank you. Optometry.
This is Steve Compton. We met and have no recommendations.
Thank you. Nursing services, they had no recommendations. They posted in the chat. Nursing home. Home health.
They posted the recommendation in the chat. I believe Evan had to sign out.
Okay, thank you.
It says, my apologies, I'm trying to scroll to it. They request that Medicaid add code T4544 to the supply fee schedule allowed codes.
Okay, thank you. Health disparities.
Yeah, this is Jordan Burke. We met on September 6th. We have no recommendations at this time.
Thank you. EMS.
This is Keith Smith. We've met several times. No recommendations, but when we have the opportunity, I would like to give some laudatory comments to groups of individuals that have made a significant change for EMS and Department of Medicaid Services.
Okay, thank you. If we have time, at the end of the meeting, we'll come back to you. If not, we'll do it next. Dental.
Yes, this is Dr. Bobrowski. The MAC, the TAC was wondering why the oral pathology payments for adults has been removed. This was a payable item. Now it's been removed, and no one from DMS has contacted the TAC as to about this or why. So we basically have no knowledge of it, of this happening. So we're wanting to know why this has happened. And the other thing is that we are working with DMS on the fees for the expansion codes, but it continues to be that even though the codes, like for a denture, for a partial denture, were added, we continue to have extremely low fee reimbursements that don't even cover the lab cost of doing the procedure. So we're working on that, but that's all I have to report. We did have a quorum at our last meeting.
Thank you. Consumer rights and client needs.
Good afternoon. Emily Beauregard, Chair of the Consumer TAC. We met and had a quorum at our last meeting and had two recommendations. The first, that DMS should not send anyone with SSI, Social Security income, a Medicaid renewal packet or RFI, request for information, in order to maintain their eligibility. The second recommendation is that DMS should provide anyone losing SSI with 2 months of ex parte Medicaid coverage when SSI ends to allow time for them to prepare and apply for Medicaid. And that's only happening with certain people. And I shared the report in the TAC. There are some other issues that we discussed that about Medicaid renewals that we have some concerns about.
Thank you. Children's Health. Behavioral Health.
Yes, we met on September 14th and had a quorum, and we have no recommendations. Thank you. I did submit a written report to members of the MAC.
Thank you. Okay, and I appreciate everybody.
Dr. Parton, I'm sorry, this is Kathy Hanna. I couldn't get off of mute earlier. I just wanted to say that the PTAC did meet on August the 9th with a quorum, did not have any recommendations, and I'll make sure the report is submitted. Thank you.
Thank you. I appreciate everybody being.
I think you skipped the IDD TAC.
Oh, is it on the?
Did I not type it?
Yeah.
Oh, it's on the second page down there. I'm sorry.
Okay, intellectual and developmental disabilities.
Yes, we met on August the 1st with a quorum and we have no recommendations.
Thank you. And then hospital. Okay, if the EMS TAC, if you have something that you very briefly wanted to bring up, you can go ahead now and do.
Thank you, ma'am. This is Keith Smith, Chair of the EMS TAC. Just wanted to give great thanks to all of the MCOs along with our billing companies, EMS folks that participated, and Department of Medicaid Services. We've been having a terrible difficulty with pre-certification, pre-authorization approval for EMS to transport non-emergency patients, and working with the MCOs. We have changed to where there will no longer be a pre-authorization, pre-certification process. It will go to a system very similar to the Medicare physician certification statement that will be obtained at the time that the patient is being picked up and will be submitted with the claim, which should help financially with a great number of EMS providers in the state of Kentucky. And I just really want to throw out a thanks to everybody, including the MCOs, for being willing to work with us, understanding the issues that our EMS providers have been having for a while now, especially with the pre-certifications and the work of everybody coming together. It was fantastic to be able to have the cooperation and everyone doing so in good spirit. So that's all I wanted to bring up.
Okay, thank you, Keith. Okay, so next we'll move to vote for election of the officers. And I believe we just.
Did you need to make a motion to accept the recommendations from the tax?
Yes, I did. Thank you, Sheila. I'm trying to.
Welcome.
I'll second that motion. Nina.
Any discussion? All in favor, say aye.
Aye.
Anybody? No? Okay, motion is moved to accept the recommendations. And now we need to go to the vote for the MAC officers. And I believe we have 3 nominees and we have 3 positions. Is that correct, Erin?
Yes, ma'am.
Okay.
I have written down Dr. Schuster for chair, Dr. Bobrowski for vice chair, and then I still have, I wrote Miss Franklin. I didn't write her first name down as our secretary because no one else stepped up to say they would like to hold that position.
Okay.
Yeah, Mackenzie has indicated that she would be willing to continue as secretary.
Why did I write down Wallace then? I apologize. Mackenzie, I wrote down the wrong name.
Yeah. It's
Okay.
Mackenzie Wallace, isn't it?
Yes, ma'am. I've got her and Miss Anissa Franklin right next to each other, and I think I just jotted down the wrong name.
Yeah. Yeah, she said that, I think she had to get off, but she said she was willing to continue as secretary.
Okay, thank you. So, would somebody like to make a motion to, accept these 3 nominees for these positions?
I so moved.
Nina, I would make the recommendation that we accept the nominees as submitted.
And this is Kent Gilbert, I'll second.
Okay, thank you. Any discussion?
Do we need to make speeches or anything?
No.
No, but now's when you distribute the lavish gifts to secure the vote. This is the point. This is the time. Gift cards are totally acceptable. So.
No speeches today, Sheila. Okay. So all in favor?
Aye.
Aye.
Any dissent? Okay, so we have our new officers. Thank you, everybody, for your vote and for the nominees who have stepped forward.
I am going to
Beth.
make a brief speech and say we all owe you a huge round of
I
applause.
was getting ready to say same thing.
Yes.
Yeah, to Beth for her incredible service to the MAC and her incredible leadership as chair. So let's all give a round of applause.
I'll echo that.
Yay.
Beth, your service to the Commonwealth of Kentucky and always following up, particularly with those needs of the vulnerable citizens that are represented on the 1915C waiver, is greatly appreciated as a parent who has 2 daughters on the 1915C waiver. So thank you, Beth, for your time.
And Dr. Parton, just from representing the Medicaid, Department of Medicaid Services, we appreciate all your service on the MAC. Look forward to your continued hopeful involvement, and you've been just amazing to work with. You were always available and accessible to us, and we're willing to have conversations about the programs and the agenda. So just thank you again from the department.
Well, thank you, everybody. It's been a privilege and an honor to serve on the MAC and to serve as the chair, I think, for the past 11 years. So thank you, everybody. It really means a lot.
Is that 3 governors, Beth? Is that right?
Yes.
3 governors that you served under. That's pretty amazing.
Great.
I don't plan to match that. I'm just telling you all.
Sheila, you'll be around for as long as there is. I know you well. You'll be around for a long time, young lady.
Okay, well, thank you, everybody. We do have reports from 2 of the MCOs. And before we do that, anybody have any questions for the previous reports from Aetna or WellCare?
No, but I just do want to pose something for consideration before we get into the MCO reports, because I fear some folks might start to drop off. I'm just wondering if 2.5 hours is sufficient time for this meeting. And I don't know that it's always been that long, but it seems that on a regular basis, through no fault of anyone's, just robust discussion and some great presentations, that we tend to run hurried and sometimes over. So I didn't know if there was a reason why it is exactly from 10 to 12:30, or if there's any interest in extending that time.
It's just always been that way, Nina. I don't think that there was any reason except that those were the hours that were chosen. I think the MAC can choose to change that if we so desire. Would the MAC be in favor of extending the time frame of the meeting?
I would for sure, because I think we're short-changing our tax all the time. And there is robust discussion beyond the recommendations. The recommendations are few but don't reflect the range of discussion and issues that are raised. And I think if we want more interplay, which I think is appropriate between and among the TACs, the only way to do that is to be able to give more time for those TAC reports. And we're, the MAC is bigger. We've added a couple of TACs and we're delving into issues. Each of the presentations given today was excellent and worthy of the discussion that we had. But I agree with Dinah that we keep running into a time crunch. I think
So would it be the pleasure of the MAC to maybe extend the time by half an hour?
I would be in favor of such a move, but I know it's very difficult for the maybe more difficult for the folks in western part of our state, but it is increasingly challenging to move further into the noon and afternoon. It's easier to move earlier on my end of things. That's just a personal preference.
Yeah, it's since our state is divided on Central and Eastern time, especially if we go to in-person meetings, it makes it very difficult for people coming from the Central time zone to make it to the meeting. Dr.
An in-person meeting, if I'm going to drive, an hour and a half or 2 hours to get somewhere, then I assume camp there. So if we go to in-person meetings, a longer meeting is going to be in some ways easier to schedule around because it'll automatically take the whole day. So.
Dr. Bobrowski, you had your hand raised.
Yeah, I just wanted to agree with the other folks that have said, responded on the time is to add a half an hour is fine. It might be, and I'm in the Central time zone, but if you're going to take a in-person meeting, it almost winds up being a whole day event in terms of scheduling things. But I agree with Dr. Schuster that I really feel like that the TACs ought to be able to get a little bit more time other than just their recommendations. It's good to kind of know what they're talking about, what they're working on, even though it might extend that, 2 minutes, 5 minutes. We're all in this to provide health care, to the citizens of Kentucky. And in a lot of situations, our efforts, our expertise overlaps with each other. And I just think it would be good to have opportunity to give the TACs a little bit more time.
I absolutely agree. The TACs have been shortchanged a lot, and that's unfortunate. And we do need input from them. So speaking for somebody from Central Time, I would be more in favor of adding a half an hour at the end of the meeting and going until 1 o'clock rather than starting earlier. Anybody else have any thoughts or comments on that?
Beth, I wonder if we might just, I'll move that the MAC timeframe be extended to 3 hours with the exact time to be settled on at our next meeting, maybe.
Okay. Is that agreeable to everybody else?
I'll second that. Garth Bobrowski.
Any further discussion? All in favor, say aye.
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 Anybody opposed? Okay, thank you.
Sorry, I was muted. Aye.
Thank you.
Ashima has put something in, maybe start 15 minutes early and end 15 minutes later to kind of split the difference. So that's something to consider.
Okay, so we can put that on the next agenda. All right, MCO reports. We didn't have any questions for Aetna and WellCare, so Anthem is up first.
Okay, can you hear me well?
Yes.
Okay, excellent. Now we have an individual that's going to be helping us with the deck. Has he been given the control? All right, here we go. So, well, members of the Medicaid Advisory Council, it's a pleasure for me to be here with you today. I'm Leon Lamro. I'm the plan president for Anthem Blue Cross Blue Shield here in Kentucky. And with me here is Dr. Daniel Brunner, our medical director, and Jeremy Randall, our director of operations. I want to give each of them just a brief moment to introduce themselves, since many of you may have not met them yet. So, Dr. Brunner?
Yes, hello, I'm Dr. Daniel Brunner. By training, I'm an emergency medicine physician. I've practiced in Northern Kentucky my entire career for over 22 years. Entered the managed care realm in 2019 and became a full-time medical director 2.5 years ago here.
Jeremy?
Hi, my name is Jeremy Randall. As Leon said, I'm the director of operations, and I've been in the industry for over 25 years and here in the Anthem Kentucky Medicaid plan for the last 8.
Well, given that we've been asked to limit our remarks to 15 minutes, but there were 19 original questions that came, we're going to have to keep this at a fairly high level. But within the deck, we've made it a point to answer all 19 of the original questions. To help organize the flow, we're going to address this in basically these 6 different agenda items. Anthem's whole health and health equity business model, an overview of Anthem's membership demographics, the Anthem provider network and network adequacy reports, which will have to be at a very high level. We'll talk a little bit about our operations excellence metrics and profile our member services. And then if time permit, we'll talk just briefly about quality and quality improvement. I may not get a chance to go all the way into the material that is in the appendix, but that is, I'll bring that to your attention as we move. So as we go into slide number 3, the vision of Anthem Blue Cross Blue Shield Medicaid is to improve the health of humanity. Our primary way to do that here in Kentucky is through a process we call whole health. For me, whole health has evolved over time. It used to mean the combination of physical health and behavioral health, but more recently we've recognized that the concepts of health-related social needs, otherwise known as social determinants of health, also need to be taken into consideration. For Anthem Medicaid, whole health requires whole teams, and whole teams include our care provider community and the community at large. Our model places the member in the center of our thinking. It integrates all of the disciplines within the health plan, and our local business partners and communities are an active part. An ultimate goal is to identify and eliminate disparities and achieve health equity with purposeful actions and dedicated strategies. Whole health takes the whole health ecosystem working together to achieve positive results. As depicted in the visual to the far right, Anthem Whole Health starts with analyzing data, determining our customer needs, and then we work with customers and other community members to see where we can make a positive difference. Another element of our business model is the purposeful efforts to achieve health equity for each of our subpopulations, trying to eliminate the inequities that do exist. Our planning and strategic process focuses our efforts in areas most needed by our membership. And as we can see from slide number 4, beginning in 2019, our planning cycle, Anthem reinvented itself using Elevate whole health approach of strategic planning. The results of this detailed process have identified 8 major areas of focus. Those areas of focus are listed on the right-hand side of this slide. And it's no accident that we begin with decreasing crisis events from behavioral health and substance use, since that is the area of greatest need for our specific population. You can see other key terms here: cancer, preventive care, chronic disease, diabetes, hypertension, dental visits, birth outcomes, mortality and morbidity rates, and food and housing. For a couple of years now, Anthem Medicaid has been producing what we call our Insights Dashboard. The numbers that you see displayed on this slide are for the year-to-date September 2023 results. Since there's a lot to unpack here, let me orient you to the slide. Beginning in the top left, you can see Anthem has paid over 3 million claims for $488 million. These claims on average are paid in 12.7 days, with 96.4% of them processed within 30 days. The top right outlines our call center statistics, in which we have answered 88,000 provider calls at an average of 17 seconds and answered 122,000 member calls at an average of 13 seconds. Anthem Medicaid has paid nearly 2 million in prescriptions in 2023. 35% of our membership utilizes the pharmacy benefit, and 87% of the time it is with a generic drug. The top 5 prescriptions by utilization are those prescriptions for cardiovascular disease and hypertension, antidepressants, other behavioral health topics, allergy and pain management, analgesics. In the center of the page, one can observe from our quality measures, 2022 measures are highlighted in blue, 23 measures are highlighted in orange, and the year-over-year change is highlighted in green. Just to the right of the quality measures is a couple of clinical utilization statistics you might find of interest. In 2023, admits per 1,000 is 46, down from last year's 53. Days per 1,000 is 260, also down from last year's 287. ER visits per 1,000, 645 is up from last year, 623, and telehealth per 1,000 is 966, down from 1,651 in 2022. At the far right side of the page is our membership and community outreach events. And one of the most intriguing statistics on this dashboard, on the bottom right-hand side, are the top 5 diagnoses. The left column is based on claims paid amounts, and the right column is based on count of claims. It may surprise you to see that Anthem Medicaid, our top 1 and 2 from both lists are opioid dependence and other stimulant dependence. Number 3 is either sepsis in one venue or alcohol dependence in the other. And then rounding out the top 5 that are mentioned in either category, chemotherapy, hypertension, and generalized anxiety disorder. Let's turn to our membership slide on slide number 8, because Anthem, when it came, let's move on to this, keep moving, Brad. Slide number 8, we're going to give you a little bit of a profile about the Anthem membership. As you can see, Anthem serves about 180,000 Medicaid members. But one thing may be less obvious is the mix of members that we serve. 49% of our membership is the TANF expansion membership. In other words, those childless adults or the working poor that came into Medicaid eligibility back in 2014. One can also notice from this slide that Anthem's membership is evenly spread throughout the entire state, with 6% in Region 1, 9% in Region 2, 21% in Region 3, 16% in Region 4, 23% in Region 5, and so on. We also have a pretty good age distribution. In addition to our continual, as we think about where we are right now, in addition to the material on this slide, it's important for us to focus on our network adequacy. And as we think about this, Anthem Medicaid has an extensive and comprehensive network because our Medicaid network is derived from our commercial network, which has been being built for the past 85 years. The contractual access requirements for MCOs, as we heard from Angie just a little bit ago, are threefold. The first requirement is providers within a certain mile range for urban or rural settings. Slide 10 here outlines some of Anthem's access results. The first column outlines the provider category. The second column, the accessibility standards. The third are the unique count of providers of each one of those provider categories, and then the percent of membership with that access. And the last column is the average distance to one provider that, based on member zip codes. So as you can see here, as a for instance, 110 hospitals, 6,229 primary care providers, and we can just kind of go all the way down through each of the rest of these specialty types. Slide 11 outlines Anthem's compliance for use provider types for each region of the state. And as you can see, 100% compliance for each of these areas as outlined by the time and distance requirements. When we look at slide 12, the second compulsory requirement for provider is a member ratio requirement. You can see the fourth column over, the accessibility standards ratio of a PCP to members is 1 to 15. You can look in 2020, our results, 21, our results, 22, our results, and you can see that where the ratio is 1 to 1,500, our ratio is 1 to 16. So in essence, Anthem dramatically meets any and all of these goals. Slide number 13, the third compulsory requirement for providers is to make care available within certain timeframes. And this slide outlines the last 5 quarters of appointment availability standards based on our quarterly survey results. I do want to point out that staffing shortages in our post-COVID environment are placing significant pressures on offices to meet some of these access standards. Some of the things that we're trying to do, in addition to our continual network recruiting, is to promote digital technologies and telephonic technology solutions to provide increased access to Medicaid membership. And then the last point that I would like to make is that in addition, we have made strategic investments to try and help train up the next generation of healthcare providers. Over the course of the last 3 years, we've invested over $700,000 in local colleges and universities to provide scholarships for individuals who agree to practice in rural settings here within Kentucky. Slide number 17, to briefly discuss some of our other questions, Anthem has approved 355 member requests for out-of-network providers. And slide 18 talks about our 12-month rolling average, where we have had to execute 45 single case agreements where services were simply not available in the state of Kentucky. That is a little bit less than we experienced last year. I'm now going to turn the time over to Dr. Brunner, our medical director, to talk about some of our clinical insights from his perspective. Dr. Brunner?
Thank you, Leon. We go to the next slide, Brad. We've seen an overall decrease in hospitalization rates since 2021, with a slight increase in behavioral health hospitalization rates the first quarter of this year. Over this time, we've seen an increase in electronic medical record access to facilities. With this, we can see in real time the intensity of our members' needs and offer observation care. We can also coordinate post-discharge care through our case management teams. The cost per admission has decreased overall, but there's a slight increase in behavioral health cost per admission from 2021 to 2022, and to date, it has returned to that of close to that of 2021. We've seen a fall in the hospital readmissions with the prior authorization process in place for physical health. Case management and social determinant of health teams can coordinate with providers. And post-COVID, primary care physician offices were able to see patients for disease management and post-discharge care. While the readmissions per thousand have declined, the cost for readmissions has increased steadily over the past 2.5 years. ER utilization overall has fallen since 2021. There's an increase in behavioral health emergency room visits, and these are driven primarily by anxiety, major depression, and substance use. Despite the fall in the ER visits, the cost per visit for ER utilization has dramatically increased over the past 2.5 years. Post-pandemic, we've seen our top diagnoses shift. Our top 4 expenditures this year to date are largely substance use related, including opiate, stimulant, and alcohol use. And also added to that is general anxiety. And due to vaccine hesitancy, encounters for immunizations have dropped, but are still in the top 10, our top 10 list, where child well visits have remained stable. Regarding our prior authorization process, we are continually reevaluating the process. We strive to simplify and streamline the process to ease the administrative burden on providers and their staff. The majority of prior auth requests are turned around within 24 hours. Our digital availability and Epic Payer platforms are tools used to help simplify this process. We utilize Millman Care guidelines and ASAM for utilization management reviews, which are peer-reviewed, evidence-based, nationally recognized criteria. I will now hand off to Jeremy.
Thank you, Dr. Brunner. Next slide, please, Brad. So first, I'd like to talk about our claim denial rates. On this slide, you can see our overall denial rate as well as the top 10 denial reasons, both metrics going back to 2021. And I'd like to note that as circumstances change, Anthem will proactively adjust certain of these denials, trying to save the provider's office from making a phone call or having to submit an appeal or email the provider rep. So for example, looking at the second highest denial reason there, if that registration changes at all after the fact, we will, on a monthly basis, identify all the denials impacted by that and have them adjusted. Next slide. Yeah, on this slide, you will find a count of all the audit requests going back to 2021. Anthem offers multiple methods to fulfill these requests, including via the Availity provider portal. And on the next slide, you will find the same volumes broken out monthly. Thank you. Next slide. And up next, you'll find a snapshot of our value-added benefits. And we would ask for the community's assistance in educating members on our value-added benefits. It is our intent that we want all members to be aware and appropriately utilizing these benefits. In addition, we offer multiple tools to support members with their whole health. And some of these are digital, like a smartphone app. Some are a vendor. But all are trying to wrap around the care that is provided in the community. And we have mentioned social determinants of health, and here you can find how our members' needs are reflected in the SDOH referrals we receive. You can see that 36.8% of the referrals are related to housing. That is our number one. Thank you. And with that, I'll turn it back to Leon.
So I think in the interest of time, just first off, I want to thank everyone on this call for your service to the Commonwealth. Special emphasis to those who served over the course of the last 11 years, Dr. Barton in particular. I hope you will join me as we think about this. The challenges that we face as a state today are going to require the entire community to come together. As we strive to improve the lives of humanity here in Kentucky, I want to thank you for the opportunity we have to be able to continue to serve. I've got an amazing team here, and our desire is to be able to help you, help our members. And so there's many things we want to address with this particular presentation. There's a lot of material that we did not cover that is in the balance of the deck, but I think in the interest of time and out of courtesy to others, we will surrender the mic.
Thank you very much. Does anybody have any questions? Okay, we appreciate the information and we will go through it, and then at the next meeting, we may have questions as we've had more opportunity to go through the slides. Thank you.
Thank you for the opportunity.
Thank you.
Thank you.
Okay, next up, United Healthcare.
Beth, United was moved to November per Dr. Cantor's request that that we had agreed on.
Okay. Okay, so are we doing 3 in November?
Yes, ma'am. You and Dr. Schuster said that that was okay to move it.
Right. Right. Okay. All right then. Well, that's not too bad. We're 21 minutes over, 22 minutes over. Anybody have anything else that they'd like to bring forward? Okay, I appreciate everybody's time and willingness to stay with the meeting. And I also appreciate all of your comments. It really means a lot to me to have the support for the MAC members, and my practice is made up of a lot of Medicaid patients, and my heart is with them and with providing the best health we can for them. So thank you, everybody. Would somebody like to make a motion to adjourn?
I'll move that we adjourn, and thank you again, Beth.
I'll second and thank you, Beth.
Thank you, Sheila and Nina. Any discussion?
No. Just thank
Okay.
you, Beth. Thank you.
Just gratitude.
Thank you.
Yes.
I'll probably be here in November. I haven't heard that I have a replacement yet. So if I am, I'll look forward to seeing you all. So all in favor, say aye.
Aye.
Anybody opposed? So moved. Thank you.
Bye, y'all.
Bye-bye.